Hello everyone, my name is Jun Chul Park. I'm a professor in Yonsei University College of Medicine in Seoul, Korea. It is my great pleasure to introduce our recently published article in GIE, evaluating the efficacy of novel hemostatic powder compared to traditional treatment in nonvariceal upper GI bleeding, which is a multicenter randomized non-inferiority study. With the aging of society and increasing use of antithrombotic agents and non-steroidal anti-inflammatory drugs, the number of patients at high risk of bleeding has increased. Therefore, sufficient and effective treatment of acute upper GI bleeding is required, which can be clinically challenging in some cases. Although conventional endoscopy treatment is considered the gold standard for achieving hemostasis, conventional treatment can be technically challenging depending on the bleeding site and etiology and may not be optimal in some cases. Recently, a new modality, hemostatic powder, has been shown to have several advantages over conventional method in that it is a non-contact method and is easily applied for the treatment of GI bleeding. Several hemostatic agents are available on the market. However, prospective RCTs are still lacking to determine whether they have an effect comparable to that of existing conventional method. In this study, we used CGP-003, which is manufactured in South Korea, which is a recently developed hemostatic powder composed of absorbable and adhesive hydroxyethyl cellulose, which contains an epidermal growth factor. To date, there have been no multicenter prospective RCTs conducted on the efficacy of CGP in non-variceal upper GI bleeding. This prospective multicenter randomized open-label controlled trial was conducted at 4 referral hospitals, which is one of the biggest institutions in Korea. We enrolled patients who underwent emergency endoscopy for non-variceal upper GI bleeding. The patients were randomly assigned to either the powder or the conventional treatment group. Conventional treatments included electrical coagulation and hemostatic clip. A total of 218 patients were enrolled. The powder group has 108 patients and conventional group is 110 patients. Initial hemostatic was achieved in 96.3% in the powder group and 91.8% in the conventional treatment group. So these two groups show a similar rate. A total of 207 patients were followed up for 30 days. The only rebleeding was like 3 days of powder was significantly higher than that of the conventional treatment group. And additionally, 30 days rebleeding rates were also significantly higher in the powder group than in the conventional treatment group. In the subgroup analysis according to the Forest classification, the rate of rebleeding did not differ between the powder and the conventional treatment group. We also calculate the difficulty experienced by endoscopists regarding the endoscopy treatment. Higher scores indicate the more difficult cases. So the results show that the procedure time was significantly shorter in the powder group than in the conventional group among trainees and experts. Additionally, the difficulty of the procedure was significantly lower in the powder group than in the conventional treatment group among trainees and experts. And no adverse events were associated with CGP powder. Our study shows that this hemostatic powder is safe and can be used as an initial endoscopy treatment for non-variceal upper GI bleeding. However, we should carefully monitor for rebleeding after initial treatment. The mechanism of hemostatic powder is that it comes into contact with moisture, rapidly produces a gel matrix, and forms a stable mechanical barrier that adheres to and seals in the bleeding site. Therefore, substantial early rebleeding could occur owing to sloughing off the protective barrier. Considering the significantly higher rate of delayed rebleeding with CGP powder, further studies are required to compare the length of hospital stay, readmission rate, need for surgery and cost between the powder and conventional treatment group. Therefore, the significance of this study is concrete in suggesting hemostatic powder as a potential treatment for emergencies or as a bridge therapy. I'd like to extend my gratitude to the investigators at multiple centers who worked together to support this study, particularly given the challenges in patient enrollment. Thank you for your attention.